as you saw yesterday and today is the same, CBDN is highly engaged with the federal government across multiple partners, NIH, NCI, ARPA-H now. All of us are fairly familiar with those enterprise contexts. For me, it was a learning curve to learn about the role of ONC, the Office of the National Controller. As a traditionally trained biomedical researcher, I didn't think ONC mattered to me. And it wasn't until we really began to build architecture as part of Kids First, tried to implement ways to extract data from electronic health record systems, tried to understand better what might be the ways that we can standardize the exchange of data, that we came upon FHIR, F-H-I-R, and you'll hear a little bit about that. CBTN and the work we did was the very first, to our knowledge, data sets within the NIH context that started to use FHIR as a research architecture. For most of us, when I say FHIR, it sounds like a cute term. What does it actually mean? Most of the conferences we are at, we still have to define, as Ash pointed out yesterday, what is an API or an application program interface. I think that's one of the challenges we face, is that we have these technologies and emerging contexts intersecting with biomedical enterprise in this research care framework. Over the last year, we've been engaging ONC increasingly around the research care model, right? Most of our patients are in this in-between space between participating in research and getting care. And that's a very different context. And ONC and its director, Mickey Tripathi, have leaned in heavily to have these discussions with us. How can we leverage the work that ONC does to intersect with our enterprise efforts within CBTN? So it's a privilege for me to introduce Dr. Kidder today, who's here on behalf of ONC. And for me, this is really the first public engagement of CBTN with ONC. I think they're going to be a great strategic partner for us longer term. ONC is doing amazing things. Almost every single NIH meeting I'm at, ONC is now there as a presence. So I think they've really transformed the landscape of healthcare and will continue to do so. And so it's a pleasure to introduce Melinda today.
So as any government program, I have to give you the disclaimer that I will do the best in my ability to represent things appropriately, but please go to our websites to look at specific laws or rules. The Office of the National Coordinator, which we were formerly known as, and I'll go into our name change here shortly, we actually started back in 2004, so we just celebrated our 20th anniversary. And in 2009, the HITECH Act became a reality, which is when, if you were around in healthcare then, that's when we started putting in all these electronic health records and having to certify for funds from CMS. So that's pretty much when I started in with health IT. My background, of course, is nursing. I worked in critical care and surgery for many years prior to coming into health IT. And so when they came about with the electronic records, I'm a little bit of a geek or a nerd, however you want to say it. And I thought it would be very interesting for us to be able to do this. In my mind, my goal at that point was, from my husband's standpoint, I walk into a doctor's office, I have to fill out a stack of papers, and I have to do this every year, and I have to do it at every doctor's office. Fix this. Well, we haven't gotten there yet, but we're working on it. I still hear that every year from my husband when he goes to doctor's offices. I thought you were going to fix this. Anyway, so the point is we're working there. Sometimes it's like turning the Titanic. So that was the HITECH Act of 2009. In 2016, the 21st Century Cures Act came about, and that's when we started seeing some more technology around interoperability and being able to share the data from one place to another. So here is a little bit about our priorities. The biggest thing that I think is important for this group is interoperability. We want to be able to share data, as was mentioned by the first gentleman, to be able to better care for our patients. We want better health. We want to be able to share this data so that we can improve our treatments. And I am moving very quickly because I have a short time frame. So I did want to mention, if anybody wants to delve any deeper into any of this, please reach out to me. I'm more than happy to speak with you or connect you with someone at the office. So here's what we do. We deal in standards, which most of you are familiar with, but you may not realize they come from my office. We invest in, develop, and promote programs and policies that lead to greater consistency in the health data. So part of that, of course, is certification. So we set the rules for the certification. And like I said, if you're around long enough, you remember meaningful use stage 1, meaningful use stage 2. We did stage 3, and then we went into promoting interoperability when the Cures Act came out. And all of those certification standards are set by my office. And then they are, checked or certified by third-party agencies. And of course, the third part of that is exchange. We want to make sure, as I said previously, that we exchange and expand the ability to be able to exchange. We also work with state and local agencies to be able to advance the development of health IT capabilities and establish that transparency along that data sharing. So taking us back a little bit, back to that certification, at this particular point, we pretty much have every hospital on a certified system. There are some concierge hospitals out there that may not be on a certified system, but we're at least 96% or greater hospitals that have a certified health system, and about 80% of offices, physician offices. So we're improving, but we still have a little ways to go there. Again, we set the minimum standards for those, so you'll know that what should be available everywhere to be able to be shared. And also, we're working on, as you'll see at one point, about AI. AI is such a big piece of what we do every day now, and that is part of where our name change came. So the whole point of our office through the HHS is for health IT alignment, hence the coordinator in our original name. We are coordinating between different agencies such as the ones you're very familiar with, NIH, CMS, FDA. And so that is part of what we do. And then, of course, our name change came around the AI. So that happened a few months ago. We're now the Assistant Secretary for Technology Policy. And the point of that change was to round up AI under our umbrella as well. So anything that has to do with AI in regards to the technology in electronic records, FDA still manages devices. They still do all the AI for devices. We do just the EHR portion of that. So stepping back just a little bit, we have what we call the U.S. core data set, or U.S. core data for interoperability. And this is a language of sorts. It's something that is made required in every system. Right now, you'll see version 1 available almost everywhere, and we do a new version every year. We just started version 6. As I said, it's like the Titanic sometimes, turning things out. Right now, every hospital that's on a certified system is required to be on version 1. As of January 1st, 2026, they'll be required to be on version 3. Yes, we skipped version 2. And I'm sure when we get to the next version, we'll probably skip a few more versions before we get there. They do have the ability to take it early, but for the most part, most of the vendors just stick with the calendar. So you can see here version 3, and version 1 was only 50 data elements. And these 50 data elements are like a universal language. So if we have systems like Cerner, Epic, Meditech, name your system, they all speak different languages. These are the translated pieces of that so that everybody can be on the same page. They're also connected to LOINC codes, to HL7 codes. I mean, they follow a common nomenclature in the background. That's how they connect all together. When we did version 3, we more than doubled it. And every year we add anywhere from 20 to 50 elements. It really just depends. Part of the cancer moonshot, which I'm sure many of you are familiar with, the White House brought out for fighting against cancer and facilitating new collaborations, brought about some different things within the community. And one of those things is the US CDI Plus versions. And you can see here we have many different things that are considered plus versions. The plus versions are in addition to the standard set of USCDI, so we do have a cancer set. I highly encourage you to go check out the USCDI website if you're not familiar with it, and also look at the different things within cancer that are there. These languages are meant for specialties such as cancer, as you can tell by looking at the screen. So we need people that specialize within cancer to put out comments. We put out comment periods for these, so we need people to be involved in what we're doing. As Adam mentioned, we're working in collaboration with many different organizations, be it private or government, and so we do need the assistance to know that we're moving in the right direction. And you'll see many articles about it here. Current use cases for the cancer program, the USCDI Cancer, is to come up with a cancer registry, minimum data set, to efficiently identify and extract the required elements to be able to be shared across different organizations. It also is to be used to enhance oncology models. So we want to make sure that we are aligning with CMS for their enhancing oncology model and drive the transformation and care coordination of these patients. And as I'm sure you're aware, this isn't just for a certain subsect of cancer, this is for all cancers. So we're very excited about what we can do when we share data and be able to help all patients with cancer. A little bit about the 21st Century Cures Act. This is where the sharing comes in. So the biggest piece of the 21st Century Cures Act for interoperability was to develop and support a trusted exchange framework. And we have done that. We have come up with TEFCA, which uses FHIR. And we talked a little bit about FHIR already this morning. And no, it's not like a campfire or the fire in your stove. It is actually, I liken it to a translator of sorts. So it takes all of these different pieces from different EHRs and carries them together to the next EHR or to the next database. It's like your Uber or your Lyft for data, I guess we could say. FHIR is very important, and we do have standards around FHIR and how it should be used and what version. Again, I'm not going to go into great detail here, but the point being that if you're on a certified system, you have to have a certain level of FHIR. And so as we move forward and continue with the certification programs, this is how everybody's going to stay up to date and be able to share the data that they need to share. So back to TEFCA. It'll take the data, it'll put it in FHIR, and FHIR will transport it over and through this exchange. And you can see we have many modalities of exchange here through public health, through private entities. There are many different ways that TEFCA is shared. It was actually started December 12th, and this is Secretary Becerra announcing. So here are some of the benefits of TEFCA. And I'll pause here for a second for you to look at the screen. There's just so many benefits. I mean, to me, I think, why didn't we do this 10 years earlier, to be honest? I know we had to wait for technology to catch up with us is probably the biggest thing. But to be able to share information, not only for cancer, but for every disease that we know is plaguing our nation is tremendous. It's just unbelievable. I know we have at least one, if not more, of these organizations in our audience here today. So these are those that are operational currently with TEFCA. And we may have signed a few more since this slide was created, but it's very good to have these companies that are more than willing to jump on board and help us do what's right for the health of our nation. So here are the use cases for TEFCA. And you'll see at the bottom, research is a future use case. We're very close. We're very, very close. But it's got a lot of technicality around research as far as privacies and different things that go around that. So not considered available for that just yet, but it's so close. And we're so looking forward to the ability to be able to share research data across TEFCA. And we have multiple different jurisdictions, and they're coming on every day. We encourage any health system that if you are not part of TEFCA or you don't know if you're part of TEFCA, ask. If they say they're not, encourage them to do so. This is where we're going to share data as we move forward. We've also already released version 2.0. So we started out with one kind of base, and we've already improved that, and we will continue to improve that. And I'm hopeful that the next version will actually include research, but don't hold me to that. It's like I said, it's complicated. And then there's my information. Like I said, I talked through that very, very quickly because I know that you have other speakers and are on time crunch, but I did want to leave a minute or two for questions if I could, just in case there were anything that you specific you'd like to ask. Please reach out to me if you have any questions after this, or if you would like for any of us to have a webinar or meet with any of your organizations. We are happy to do that. We like talking about what we're doing. We like for people to know who we are and what we're doing. We may be a small agency within HHS, but we're a mighty agency. And we do a lot of great things. And this year has been phenomenal for the things that we have done. It's amazing. It's like a culmination of Mickey's time at ASTP. So it has been a big year for us.
We've had similar experiences this took me totally by surprise. So, and the rationale for that, so that's fascinating because we have patient permission to get all their outside records. More recently, as many of us know who practice, that is done electronically through Epic Everywhere for most outside records, because we're on essentially two systems, most of us. And so that was interpreted legally by our hospital. There is a statement that says Epic Everywhere is not for research, and that's a very broad statement. But it's also not supposed to block research that patients have consented for. And so I'm wondering if you've heard about that issue and or if your office is working through that. Because what's happening right now is we then ask them to print out and fax their medical. I mean, it seems we're like in the dark ages of how we're getting those, because we do need those data. And it's actually for patient care as well. These are patients on therapeutic trials. So research is integrated into their treatment.
Right. Specifically just for research, as I said, TEFCA is not quite there just yet. As far as record sharing, I know that we have records that are shared as PDFs and emails, and it breaks my heart that that's where we're at. We are working directly with the big vendors. Epic is one, of course, because they have such a market share. So I can definitely reach out to them to find out specifics on that. I don't know if you have any other.
So I think this is really the emerging context, and I think where, for us, it's going to be a privilege to be in the midst of what is a developing ecosystem in some context. I think what you're hearing from Sarah is really this tension that our community sits in, which is that, our patients are on clinical trial research protocols, and it's in that dead zone. Is that research or is that care, right? That's defined by the...
Well, but I mean, it is care. To me, that's
we
where
agree.
you care.
Yeah.
I mean, if you're caring for the patient, granted, I know that there's probably a line there as far as when does it get past care and get to just research.
Yeah.
And that's what I said. That's where research is difficult.
But I think
because it gets to that. Where
I think
at?
I think that's the opportunity that we really have, is that, as a community where, and you'll hear from our advocates in a second, we're in this amazing position to be a use case, right, to drive that innovation, because I think we recognize why an Epic might shut off, right, access for inappropriate use or other contexts. I think some of us have been following the news around some of the ongoings with that. But I think it's such an exciting time period, and I think it's an opportunity for the pediatric landscape, and with these especially unique use cases where the patients and advocates are incredibly well informed, are leaning into that context. It's in between that patient use case and clinical use case. So I think what you'll hear is that there's tremendous excitement, but also some confusion in that setting.
Well, and I completely understand that, because like I said, there is that gray area. Okay, where do we get from patient care to research when the patient care is the research?
Exactly.
You know what I mean? I get that, and I'll definitely take that back with me.
Yeah, especially in a community that really doesn't have any curative standards of care, right? Like our patients almost all end up on a clinical trial, and that is care. We don't have anything else. So that was definitely one of the points that I wanted to make. But the other one is, and by the way, just love the tack you're taking on all of these things, because it's very patient forward, and we appreciate that. But it's not for Epic to say who can access that patient's records. It's for that patient, right? If they say share it, that has to be the mandate that we listen to. It has to be patient driven. And as speaking for the organizations in this room, because I know that they're all passionate about these kinds of things, if you need additional voices from the patient community to help push those kinds of things forward, we're here and we're totally willing to help. We want to partner and help get those initiatives through because they need it so desperately.
I agree. I am totally with you, and I believe that that's where we stand as well. It's a patient-driven market. This is not about the Epics, the Cerners, the Meditechs. It's not about ASTP. It's about the patients.
And again, to be transparent, we've met with Mickey a number of times, and the office has been all in on this, right?
Yeah.
It's really, what Bob was talking about, sort of revolutions, right? Cultural revolution. This is a cultural revolution moment, I think, for healthcare in ways that I think we get to be front and center as driver use cases for that.
So thank you so much for everything you and Mickey and others are doing. And I would just, I'm going to make a quick comment before we move on to the AI imaging demo, which is this week, the CBTN community is working through a digital innovation, working backwards mechanism. And there's different personas that have been identified: patient, families, clinicians, researchers, pharma. And today we've added as the sixth persona, the foundations and the nonprofits based on, the talks this morning and that need for them to come together. So I'm optimistic that through this, some of that guidance and prioritization of that passion and that voice on helping guide this for the community will be made. So just glad that there's a seat at the table for all these voices. Thank you so much.
I also want to give a plug for our HITAC committee. Our HITAC committee is part of the public voice within our organization. It is one Thursday a month. I think it's the third Thursday. They have a webpage. You can go on there and you can sign up to receive the Zoom link. And there is a section always reserved for public comment about the work that we are doing. This organization, this group actually has different people within the healthcare community as far as vendors and other organizations. I also attend that every month as well. A lot of great things that come out of that meeting itself, and that helps to drive much of the work that we do at ASTP. So I highly encourage, if you have not been to a HITAC meeting, to please go onto the website and find that link and sign up to come. It is about 3 or 4 hours on a Thursday, so that makes it kind of tough, but they do record them. So if you cannot make it, you can at least listen to the recording afterwards.
I just wanted to say, so I'm Jenna Lilly, Executive Director of CBTN, and just on behalf of CBTN, I know what your husband said, but you are doing amazing, amazing work and progress. Like what you're all accomplishing, version 1, skipping to version 3, you're moving so fast and it's so impactful. So we are just so grateful that you're here today and we're willing to partner, and you're making just an amazing difference. So
well, thank you. Thank you. Like I said, it's unfortunate that sometimes it takes a little while to get some of this stuff done. But in the time that I've been in health IT, from the HITECH Act in 2009 to today, we've come so far.
And I think it's accelerating. Yeah, and it's accelerating. And, the use case of connectivity is the most salient for rare disease communities, right? And so I think we're so grateful for the partnership. Thank you for being here today. You'll hear a lot from us, and we appreciate the invitation for additional input and comment. I think this is one of the areas that we as a community have a chance to inform. I think ONC or ASCP has been very open, right, for that. And I think we need more pediatric oncologists and pediatricians to provide input into this context.
Yeah, it's specialties like pediatrics that don't always get well represented, which I'm sure you know. It's general public. You may see some specialties, but a lot of times there are not the specific specialties. Right. One last plug.
Please.
We have our annual meeting coming up December 4th and 5th. So I encourage, it's free. Granted, it's not free to stay or come, but it is free. So I encourage, if you haven't or would like to please sign up and join us at the annual meeting.